Bioethics 2.0, Podcast Episode 4, The Introduction to the Clinical Pragmatism Framework. Bioethics 2.0 Podcast Episode Guide. This is Podcast Episode 4, Clinical Pragmatism. You can find this information in Introduction to Clinical Ethics by Fletcher, also known as the ICE, in Appendix 2. Clinical Pragmatism.
While there are a variety of clinical ethical frameworks that can be used to resolve moral difficulties, one, called the Clinical Pragmatism Framework, that can be found in the Introduction to Clinical Ethics textbook by Fletcher, that most closely resembles the methods of nursing and medical diagnosis. So doctors and nurses will already be familiar with this method of ethical analysis. This slide takes you through the 4 steps of the Clinical Pragmatism Framework. We will go through these briefly, and then we will spend the rest of the podcast discussing especially Phase 1, assessment of all the things listed on the slide, in more detail, and then we will talk about Steps 3 and 4 as well. The first step of the Clinical Pragmatism Framework is assessment. This includes assessment of medical facts of the situation and what contextual factors exist in a particular case, whether the patient has the capacity for decision-making, what the patient's preferences are, and what the patient's needs are as a person. In addition, this includes assessment of who the surrogate decision-makers are when a patient lacks capacity, whether there are any competing interests, what institutional factors might be in play in a particular place, and the very important component of power. Phase 2 of the Clinical Pragmatism Framework is a moral diagnosis of the problems posed by the case and options for resolution. This moral diagnosis is very much like any other diagnosis a clinician would make. It involves taking into account all the facts of the assessment and trying to make a hypothesis of what the diagnosis could be based on the contextual features of the case, and then what some options might be to provide data so that you can test that hypothesis. In this way, a moral diagnosis is very much like other diagnoses a clinician would make. It is essentially a hypothesis. Phase 3 of the Clinical Pragmatism Framework is where you set goals, where you engage in shared decision-making, where you try and implement a plan of action by means of a shared deliberative process. Phase 4 of the Clinical Pragmatism Framework takes place after the actual case has been resolved. It is where you evaluate your results. We will discuss each of these steps in greater detail.
The use of clinical pragmatism in clinical ethics.
One of the other reasons the Clinical Pragmatism Framework works so well is that it adopts a democratic model of moral decision-making. Since there is not one moral principle that should be used to resolve a case, there is not one view of the moral situation that should take precedence. This helps foster a more inclusive model of moral decision-making. So what happens here is that clinicians, and if they are working with ethics consultants, they help facilitate or guide a process of decision-making without dictating or engineering the outcome. As I said, the moral diagnosis is very much like a hypothesis, and in very much the same way that you use tests and other diagnostic tools to help fill in the gaps and help determine whether or not the original diagnosis of a clinical matter is indeed the case, the same goes with the Clinical Pragmatism Framework. Rather than using an engineered outcome or ethical principles where you already know what the answer is, the Clinical Pragmatism Framework is understood to be located within a context of what we call reciprocity. What this means is that all parties are entitled to be heard. They all need to work together, and they need to arrive at a mutually satisfactory resolution. Ethics committee members who are using the Clinical Pragmatism Framework should promote careful consideration of the range of options that are available. They need to ensure that all concerned parties have an opportunity to be heard and endeavor to mediate conflicts. If you are a clinician and you use the Clinical Pragmatism Framework on your own, the same goes for you. It's also very important to note that not every item on the 4-stage process of clinical pragmatism will be relevant in every morally problematic case. It is provided as a guideline to be all-inclusive, and although the method is presented in a somewhat linear progression, in practice you should know that these steps may occur simultaneously or in a different sequence. You may assess facts after you have a diagnosis, and these are just preliminary guidelines for you.
Balancing benefits and harms.
This is the first of the 8 ethically relevant considerations. This is the paramount traditional ethical principle in the practice of clinical medicine, and here we're balancing ethical considerations of beneficence and non-maleficence. What needs to happen here is that any outcome that should result should try as much as possible to maximize the benefits for a patient and minimize the amount of harms.
Disclosure, informed consent, and shared decision-making.
As many of you listening to this podcast know, bioethics and legal thought in the past 30 years have challenged whether clinicians should have the unilateral authority to determine what medical treatment is in the best interest of patients. The ethical principle here is respect for patient autonomy, the right of adult, competent patients to determine for themselves whether they will accept treatment is recognized in the legal and ethical doctrine of informed consent. In order to actually exercise voluntary consent, patients need at least to receive truthful disclosure from their clinicians concerning what their condition is, the benefits and risks of alternative treatments, what their prognosis is, both with and without treatments. Informed consent requires ongoing dialogue between clinicians and patients. This is known as shared decision-making.
Norms of family life.
As we all know, familial relationships give rise to moral responsibilities. And depending on the particular case at hand, it's up to ethics consultants and clinicians to determine the appropriateness and how strong the norms of family life should be relevant to a particular case. The closeness of family members, their particular histories with each other, whether there are any dysfunctional relationships within the family. All of these things are important when discussing and considering the norms of family life.
Relationships between clinicians and their patients.
Obviously, a relationship that a clinician has with a patient will be very important, especially when delving into the murky waters about ethical issues. Therefore, the trust the patient has in and the trustworthiness of clinicians can be very important. If the patient does not trust his or her clinician, communication can break down. And if the clinician is viewed as not trustworthy at the end, ethics consultants might need to be involved in a case of that nature.
Professional integrity of clinicians.
This principle plays an important role in determining whether treatment or care requested by patients or their surrogates is ethically appropriate. Patients are free to refuse treatment. That's an acknowledged ethical and legal right. However, the converse is not true. Patients are not entitled to receive whatever treatment they demand. Clinicians have no responsibility to provide treatments that they consider medically inappropriate, but these determinations must be supported by appropriate evidence.
Cost effectiveness and allocation.
Both of these considerations are increasingly at stake in questions of the distribution of medical resources and efforts to contain the spiraling costs of healthcare. The ethical principle that is relevant here is justice. Many of us are aware that managed care and other cost containment efforts are the occasion for many ethical conflicts between patients, clinicians, and now especially third-party payers. We need to have equitable procedures that must be applied in order to make ethically acceptable decisions about the allocation of medical care. The clinician is the patient's main advocate for access to medically indicated health care and entitlements to coverage under private or public insurance plans. Therefore, they shouldn't be afraid to pick up the phone or ask one of their other staff members to be the advocate for the patient and get what is required for the patient.
Culture and religion.
We should realize that for some cultures and some religions, the ability of the patient to be self-determining, the exercise of autonomy that we have in the United States, and truthful disclosure may be somewhat foreign to the cultural practices of some patients. What we need to do here is ensure that clinicians apply sensitivity and tact, and perhaps religious or cultural consultation along with ethics consultation. The worst thing you can do is just make the bland assumption that because someone is represented by a particular culture or religion, they will hold the same belief as is typical with that religion. What is best to do is what I call offering the truth to the patient. What this means is that you offer the patient, at the beginning of your advanced care planning process, before you have any information to deliver to the patient, you ask them if they would like to know the results of tests. Who would be the person to communicate with? The patient here is worthy of respect, and by asking them what they would want to do, they should be able to tell you, yes, I represent myself in these matters, don't talk to my family, or they will tell you that they would rather have you deal with certain members of their family so that you can move forward with an ethical decision.
Considerations of power.
Differences in power shape or underline ethical problems in the clinical setting and deserve special attention in furthering the principle of respect for persons and their autonomy. It is almost always the case that clinicians are in a greater position of power in relation to their patients and their family members. Shared decision-making requires sharing power. The major vehicle of sharing this power is conversation. This conversation has to evolve between the clinician and the patient's family. Shared power involves recognizing the patient's or the surrogate's moral standing and right to participate in decisions. And here, of course, one of the important things to remember is clinicians should be mindful of what type of language they use to communicate with patients. They should use language that is understandable to their patients and not use medical jargon or obfuscate in any way.
Clinician virtues.
There are several types of virtues that clinicians should possess in order to deal with ethical issues, as well as to provide basic good care. There are 9 of them. The first is technical competence. We want our clinicians to be technically competent, to participate in continual lifelong learning. The second is objectivity and detachment. We want our clinicians to be objective and somewhat detached, but what we don't want them to be is cold or emotionally unavailable to patients. The third is caring. Caring is a complex perceptive and emotive disposition to relate to persons with the aim of helping them satisfy their needs. This is opposed, of course, to objectivity and detachment. You may ask how these two things can work together. This is a very difficult balancing act, and clinicians with a great deal of experience have the ability to be both objective in gathering and diagnosing information, being somewhat detached in their relationship with the patient so they don't become immersed in the patient's issues, but they also display a very caring and compassionate disposition to their patients. Number 4 is clinical benevolence. This means that all clinicians strive to benefit their patients and do what is required for them. One of the things you need to do is to have subordination of self-interest in order to be a virtuous clinician. That means that you disclose to your patient when a referral you make will influence your bottom line. You need to say, I am here for the patient, and I am going to subordinate all of my interests while I am caring for you. The 6th thing is reflective intelligence. We like our clinicians to have the ability to reflect on the clinical literature, to reflect on their own practice, and to reflect on their own patients and their patients' experiences. That leads into the 7th clinical virtue, humility, which is recognizing that you don't know everything, that you may need to get consultations, that you may need to consult the clinical literature, and that you don't know everything in the world and that you're not, quote, playing God. Practical wisdom is the ability to access the clinical literature when you know that there is something you may not exactly know. It's basically the wisdom that's required when dealing with ethical issues. Number 9 is courage. All clinicians require a certain amount of courage, either in dealing with managed care organizations, in dealing with complicated issues with their patients, when trying to stand up to other clinicians who may in fact disagree with them. And this is a very particular strong virtue for the nursing profession. The nursing profession has traditionally been subordinated to the physician profession, and nurses now require the kind of courage to stand up and demand that they have equal standing when it comes to ethical issues in the clinical care of their patients.